Alrighty, we're gonna get started, okay?
All right, sounds good.
Alrighty. Hello, welcome everybody to today's virtual shadowing session. Today I have Dr. Sid with us. He is a PM&R resident, and we're super excited to have you speak about your experience and tell us more about your specialty. So I'm gonna hand the floor off to you.
Awesome, great guys. Thanks for having me. So again, my name is Dr. Sid. I am a second-year resident at Walter Reed National Military Medical Center over in DC. So today I'll be talking to you about PM&R as the specialty, and we'll kind of start off with introduction to what PM&R is, and then we'll dive deeper into what I see on a day-to-day basis, and we'll finish off with the case. So just a little bit of info about me before we get started. I am actually, I was born in India. I moved to the US when I was 3 years old. I grew up in Dover, Delaware, a very small place. And then somehow I ended up at the University of Miami for my undergraduate. Loved it. It was beautiful. To anybody who's watching who is a Miami Hurricane, go Hurricanes. Then applied for the Army HPSB scholarship, received it. Super blessed to have that. I'm currently a captain in the Army. Did my medical school at Philadelphia College of Osteopathic Medicine over in Philadelphia, and then I'm currently at Walter Reed for residency. Things that interest me, I love sports. I've played basketball and football for a majority of my life. Huge foodie. I love hiking, love video games, and love being at the beach. So I see some questions rolling in. Give me 1 second to keep up with them. All right, so good amount of questions. I'll try to handle all those towards the end as we wrap up, and then we will go from there. All right, so what is PM&R? So it comes from the Greek word physikos and iatria, and so it's literally termed physical and the art of healing. And there's honestly no better way to put it. That's exactly what we do, and I'll go into more detail about that. So in regards to what physiatry is and what we do, our goal is to help prevent injuries, prevent certain diagnoses from occurring. We are there to diagnose a variety of different injuries and diagnoses that will arise that I'll go into more detail about, and lots of different symptoms that we see in terms of musculoskeletal, neuro, and pain related. And then the treatment of certain disorders and what we do to help people who have either temporary or permanent impairment. So two goals that you'll see in physiatry mainly are to help restore function to the maximum capacity that we can, and then to maximize quality of life. And we'll dive more deep into that as we go on. And so overall, when you look at our field, we don't like to treat the symptom. So if you're having some sort of knee pain or shoulder pain, or you have imbalance in the height of your hip, or imbalance in the height of your shoulders, you're hunched over one way. We want to know why that's happening. We're not just going to treat the symptom. We're not just going to treat your knee pain. We're not just going to treat your shoulder pain by giving you some meds that can help relieve the pain, but we want to find out, what is the mechanical issue? What's going on? Do you have a strain somewhere? Do you have a difference in your leg length? Do you have an injury on the contralateral side that's causing you to, compensatorily shift your body in a different way, which is now affecting higher levels up? And then the rule of thumb is for any sort of joint injury is you want to look at the joint above and below to see if those joints are impacting the joint that's actually causing the symptoms, right? So if you have a knee injury, for example, you got to look at the hip, you got to look at the foot, you got to see if those are okay. Are those aligned? Are those working as they're supposed to? Not only just looking at the knee. So moving on. The physiatry as a field itself, just like any other residency, you have to finish 4 years of medical school. After you finish 4 years of medical school, you do a year of intern year, which can be composed of either an internal medicine prelim year, you could do a surgical prelim year, or a transitional year. I myself did a transitional year. We can get into those as we go on. They're very different by nature, and I personally chose transitional year because it allows you to kind of have a little bit more flexibility with electives, and you can gear it a little bit closer to the PM&R years that are going to be coming up after that. So after you finish your intern year, you do 3 years of PM&R training. I'm currently in my first year of PM&R training. So finished my intern year in my second year of residency overall. And then there are much more subspecialties that you can go into after that. So we'll get into those a little bit on the next slide. So after you finish your PM&R residency, there are a set amount of ACGME accredited subspecialty fellowships that you're eligible for. ACGME is the overall accrediting board for all medical training after you graduate medical school. So residency and fellowship are all governed by ACGME. And so within those fellowships that we're eligible for include hospice and palliative medicine, neuromuscular medicine, pain medicine, pediatric rehabilitation, spinal cord injury, sports medicine, and traumatic brain injury. So there's very diverse, a lot of things you can subspecialize into. There's a good amount of specialists around that, love what they do. And you can kind of figure that out as you're navigating through residency. You'll figure out what you're more interested in. And if you want to become even a better expert at it, you do a fellowship. So the guiding principles, as I mentioned earlier, is 2 big goals. You want to improve function, you want to improve quality of life. The one thing I love about PM&R right off the bat is there is a great system of integrated care. So in my field, we work heavily with the orthopedics, the neurologists, the physical therapists, the occupational therapists, the speech therapists, the nurses. And so it's a multimodal approach for treating and a multidisciplinary approach for treating. Overall, our goal is to combine both pharmacological but also non-pharmacological modalities to help them. And the end goal is to prevent them from surgery, right? So perfect example of that is a 35-year-old comes in with, knee osteoarthritis because they were an ex-football player in college and they put a lot of wear and tear into that joint. Obviously, you don't want to give a new knee to such a young patient. These replacements, these joint replacements, which you guys might not know right now, they only have a certain lifespan before you have to re-replace it. And so, for example, with something like a knee replacement, they last anywhere from 10 to 20 years before you have to go in and go back in and either replace it or make some modifications. So you want to avoid surgery as long as you can in a lot of these patients. And at any time, you always want to start with conservative therapy and then slowly bump it up. And that's where the role of PM&R really, really comes into play. We do a lot of different things to help prevent people from having to go to surgery. And we'll dive a little bit more deeper into that as well. So, and as I mentioned, you coordinate with a lot of interdisciplinary teams. You get to learn from a lot of different specialties. It's really great. Good team integrated approach. And as I was kind of already mentioned in the last slide, you work with orthopods, rheumatologists. You work with neurology, you work with neurosurgery, a lot of different disciplines, because a lot of times you're either going to treat the patient up until they need surgery, or you're seeing these patients after they had surgery, because either before or after they're candidates for rehab. So as long as they're at the point of surgery or after surgery, you're probably going to be seeing them. Some of the cool things that physiatrists get to do, which most specialties do not, is we do get to do something called electromyography, and for short term, that's called EMG. That's basically a tool that we use to assess where there's a nerve injury, at what level, because at any point, you know, these nerves are traversing through a large portion of our body. So for example, the nerves that innervate your hand come all the way from your cervical spine, right? So when you see someone who has numbness and tingling in their hand, you can't just assume that it's their hand that's the issue. So in order to help determine that, we are trained in something called EMG, electromyography, and nerve conduction studies that we use this machine with kind of these like pins and needles that we stick into muscles and test the firing of the nerves. And we can kind of locate at what point do we feel like that injury took place. One of my favorite modalities to use in the clinic, which is going to be the future of PM&R, as well as a lot of different specialties, is using the ultrasound. Ultrasound is a great, safe alternative to exposing patients to radiation, especially if you're thinking it has to do with some sort of muscular injury or tendinous injury, or even you can look at joints fairly pretty well with ultrasound nowadays. And that technology is just getting more and more advanced to the point where you're seeing things in very crisp detail. So that really helps us when we go to do these advanced spinal and joint injections that we can discuss later. And another thing, like we said, is you know, at the end of the day, surgery is great and all, but anytime you can avoid it is amazing, because surgery, as much as it does good, a lot of it has a lot of complications with it, which include infection. And you know, once you cut, you can't ever go back. It's that incision has been made. You're going through a lot of different muscle layers, different nerves that might get affected. So there's a lot of things that you have to consider before you send someone for surgery. So a little bit about practicing on the inpatient side, and I'm sure people have been over this with you guys, but you know, when I was in undergrad, I didn't really know what inpatient versus outpatient meant. So inpatient is referring to anything that occurs within the hospital. So management within the hospital is what inpatient is. Outpatient medicine is anything in a clinic. So clinic-based long-term care, long-term follow-up. So on the inpatient side of things, we see a lot of patients who come status post having a spinal cord injury, you know, motor vehicle accidents, and they have traumatic brain injuries. They have strokes, which is a huge population that we see, multiple sclerosis, burn victims, and a lot of pediatric and musculoskeletal congenital disorders. And within these inpatient hospitals, anytime you're on a rehab floor, you're going to be surrounded by a great team. You're going to be surrounded by a physical therapist. You're going to be surrounded by an occupational therapist, and we'll kind of break those down. So physical therapists, they help with improving strength and function, with strengthening exercises, range of motion exercises, and they kind of assess how stable they are, what's their balance like. And occupational therapy is there to help with activities of daily life, right? So are they back to the ability to brush? Are they back to the ability to shower themselves? Are they back to the ability to dress themselves? So a lot of these things, when people have spinal cord injury, strokes, you'll have weakness, and let's say it's your dominant hand, a lot of these things change. So occupational therapists are great about helping restore that ability to brush using different modalities, put their sock on with, you know, different equipment that can help them without having to bend over if they have had a recent low back surgery or something like that. You have speech therapists involved who are great for assessing whether a patient is able to swallow, you know, food, liquids, and stuff like that, so they don't accidentally aspirate it into their lungs, which can lead to infection. Speech therapists also work with cognition and trying to figure out, you know, after their stroke, are they back to it with their cognition, you know, where their level of cognition is, are they oriented? Are they able to problem solve? Are they able to remember what meds they have to take on certain days? And then you have the neuropsychologists, which are great, especially in these cases for like traumatic brain injuries where you have a motor vehicle accident, they had a severe concussion, and there's all sorts of symptoms that people experience afterwards. So there's a state of confusion, disorientation. There's some people have PTSD afterwards. You have people who have difficulty with making new memories. So amnesia is a big part of that, post-traumatic, traumatic brain injuries. And so there's a lot of things that are in play. And so the job of a physician, a PM&R physician in that area, is to supervise kind of all of those multidisciplinary team, but also to kind of help guide the medical management side of things. So when you see someone who comes in with a stroke, which you guys are probably learning about right now, in order for you to get a stroke, you probably had a lot of risk factors, right? Or you have some sort of coagulopathy disorder that you didn't know about. And so these people aren't coming in with perfect blood pressure. They're not coming in with, perfect blood sugar levels. They're not coming in with their labs looking amazing. So we not only manage all of those things, but we also manage the pain medication side of things, the meds that will help reduce contractures. So a lot of people with strokes, their muscles get locked up, so they can't have any sort of range of motion. And we help do the simple modalities that are non-pharmacological as well. So, just the other day, I dry needled someone's neck who they couldn't turn more than like 20 degrees to the right. And so dry needling is a technique where you go in and you kind of break down some of those muscle fibers that are contracted and help it get some more blood flow to it. And so there's a lot of different things that we do on the medical side of things that kind of overlap and help out the other therapists. And every single week we have team conferences where everybody meets up together and kind of goes over what's really going on with this patient. How can we improve their function? What else can we do? What's their status going out of the hospital, and what support system will the family need? Because a lot of these patients, you're not only thinking about the patient themselves, but imagine the burden of the family that now has to take care of a patient who's post-stroke. They used to be the supplier for the family. They got the groceries, they mowed the lawn, they did all these things, and all of a sudden that gets taken away from them, right? And so you got to think to yourself, what needs does this family have after leaving? How can we help that out? So I won't harp on that too much, but there's a lot that we do on the inpatient side. Personally, I'm in love with outpatient medicine. I love to sit down with my patients. I love to talk. I love to kind of explain what's going on with their diagnosis, and I love to diagnose. And so one of my favorite things is, seeing a patient for ankle pain, knee pain, shoulder pain, whatever. They come in and they tell you that they have low back pain. And as you guys move forward in your medical careers, you'll realize there are a bajillion generators for pain. And so you see someone with low back pain, it's a very broad term that's used in the United States, and low back pain is, I have to look this up, but I think it's either the number 1 or number 2 complaint in all clinical settings. And so you see someone with low back pain, there's a lot that goes into it that you have to really diagnose through. So, and you do that with different physical exam tests that you learn throughout your residency, throughout your medical school, that kind of help you narrow down where this pain is actually coming from. And same thing with shoulder injuries, and same thing with the nerve injuries that I was talking about with, for example, the hand. Is it coming from the neck? Is it coming from the brachial plexus in the shoulder? That's coming after the cranial nerves and the cervical nerves have exited. Where is it coming from? Is it coming from the wrist where the carpal tunnel is, and is that where the median nerve is getting entrapped? There's a lot of things that go on where you really have to do some deep diving, but that's one of the best things about outpatient medicine. You get to trial and error a lot of things, and you get to see a variety of different injuries. So you're not only seeing sports-related injuries, as I was mentioning, You get to see a lot of neurological issues. So some people, after having a spinal cord injury, will have neurogenic bowel or bladder, where they don't have control of their bowel or bladder movements anymore. You'll have people who come out with spasticities, and you get to do Botox injections to help relax the muscle. You get to do something that's really new in our field, something called regenerative medicine, where a lot of these people who have arthritis and all of these joint issues, we're able to go in and do something called platelet-rich plasma, which is super new, stem cell injections, super new, prolotherapy, super new, where the idea behind it is it's restoring some growth factors to the area. So there's a lot that goes on the outpatient side. You get to, like I said, treat a variety of patients, and it's a great lifestyle. Typically 8 to 5 is the hours, 8 to 4 is the hours, and Monday through Friday. So it's very, very rewarding and very great lifestyle as well. And then, like, as inpatient, as an outpatient doctor, you also heavily rely with communications with orthopedic surgeons, neurosurgeons, and neurology. So some conditions that we treat, so trauma and injuries, we see all sorts of things. So from sports to work-related injuries, to crush injuries, like a lot of construction workers, stuff like that, to even simpler things like you work at a desk job and your wrists are constantly like this. High chances that you're eventually going to develop carpal tunnel. So we also deal with acute and chronic pain syndrome, so back and neck, with diseases such as osteoporosis and arthritis. Something in the military setting we see all the time is amputations, and kind of how to rehab them back, how to help them gain their functionality back, gain their independence back. With cardiovascular issues, so currently right now on my service in the hospital, we have a patient who's coming out of a cardio bypass surgery, and they also get deconditioned. He also happened to get sepsis infection and kind of went downhill. So when somebody's in the hospital for quite a long time, regardless of what they're there for, they do get deconditioned. So they get sent over to us to help them rehab appropriately. Pulmonary, so COPD patients and other respiratory dysfunctions. We see a lot of that. And right now there's a lot of literature coming about, how the PMR field can help with the COVID pandemic and all of the kind of the pulmonary issues with that. And then, yeah, there's a bunch of other stuff. And like I said, neurologic, we deal with spinal cord injuries, TBIs, which is traumatic brain injuries, strokes, MS, peripheral neuropathy. What that means is basically any nerves that are on the periphery. So like anything that's in the extremities, things that deal with sensation, things that deal with like muscle weakness. And we see patients who have, chronic neurological disorders too. So like Parkinson's, dystonias, and motor neuron diseases. And so, like, to give you guys an example of what we do, so for like something like traumatic brain injury, we help improve their cognitive social functioning skills and help them figure out how to return back to work. For acute disc herniations, we can do everything from spinal injections to providing them the appropriate therapy regimen, to helping them kind of with different modalities of pain medications to help them get to the point where they can actually tolerate therapy, all without avoiding surgical fusions or sending them to neurosurgery. And then for other things like joint replacement, everybody who comes out of a joint replacement, they're told to be on a protocol where they're not allowed to move the joint for a little bit. They'll have certain restrictions. Pain will limit them from having range of motion. And so all of our job is to basically increase that range of motion, improve their functionality, and try to get them back to doing what they're used to doing. Sprained ankles, very common thing we see in our practice. Like I said, we see a lot of sports stuff. The important thing with things like that is you got to understand your patient population. Are you dealing with an athlete who's going to heavily rely on that ankle, or are you dealing with, like my mom who can just walk around? So you tailor your kind of medicine based on the patient as well. So like I was saying, post MI, like post heart attack, you're going to deal with cardiopulmonary rehabilitation, spinal cord injuries. You see a lot of spasticity. Basically, they're having like either like difficulty with having the ability to stretch, or muscle contractures, or even just spasms. And then another thing with spinal cord injuries is if the spinal cord injury took place in the higher thoracic and higher cervical regions, they will have sometimes a syndrome which can lead to their vital signs being all over the place. They can have high blood pressure out of the blue. They can have high heart rate. So there's a lot of management that goes on that side as well. And then post-stroke, obviously, goals is to increase cognition, mobility, range of motion, spasticity, and all that jazz. And then so we can do a case that I think will be a pretty simple one, but to kind of give you guys an idea of what we kind of see in our outpatient clinic. And then I'll open up the floor for questions, and then I can talk about other cases if you guys would like, and we can kind of tailor based on what you guys want to hear. So you have a 44-year-old female presenting with chief complaint of bilateral knee pain. She states that the pain began in 2014 and has gradually worsened. She states that the pain occurs deep inside her knee, and she mentions that the pain is worse with prolonged sitting. So basically, after she's watched a movie or watched I don't know, like sat down for a lecture, or going up and down stairs, and with exercise. She says that rest does help with the pain, and she says that she has not had any relief with physical therapy thus far. And most of the time, physical therapy is limited due to the pain that she's having. She currently rates her pain 6 out of 10, and she states that she's no longer able to run anymore because after half a mile, it's just unbearable pain. So on physical exam, you see that the medial aspect of the patella is a little bit shifted laterally. And then she also has tenderness to palpation along the lateral retinaculum, which is basically the outside of the patella, your kneecap, that wraps around on the side. It's a nice kind of connective tissue that holds the patella in place. Anytime you have any sort of musculoskeletal injury, you want to test muscle strength. And so the only abnormal thing that she had was 3 out of 5 muscle strength with abduction of the leg. Abduction means bringing the leg out to your side, basically. And are you guys familiar with the grading scales for muscle strength or no? I'm gonna just assume that you guys aren't. I know some of you guys might be, but so basically the grading scale for muscle strength is 1 through 5, 1 being basically like a flicker of a muscle contraction, 2 being the ability to have muscle contraction with gravity removed, 3 being muscle contraction against gravity. So you have the strength enough to be able to contract a muscle against gravity. 4 out of 5 strength being the ability to contract a muscle with partial resistance. So if I'm asking you to curl your bicep, but I'm giving you a little bit of resistance and you're able to still do it, that's 4 out of 5. And then 5 out of 5 muscle strength is your ability to contract your muscle against 100% resistance. So I'm trying my hardest to not let you curl and you're still able to do it. And so the norm is 5 out of 5. So everything else other than her ability to abduct her legs, which is bringing them out, basically extending your leg out to the side, was normal. So she had weakened hip abductors. And then that little term that I put, SILT, I apologize. That just means sensation is intact for light touch. So that basically means while we're looking at a patient, we are just symmetrically going by palpating their quads, the sides of their thighs, the front of their leg, the back of their leg, the sides of their legs, the toes, and the foot to see if the sensation is the same on both sides, if they have decreased sensation or increased sensation. And then DTRs is deep tendon reflexes. So you guys have seen the kneecap reflex, you guys have seen the Achilles reflex. Those were equal and those were normal. So some special tests that we do, I don't expect any of you guys to know these, but with anything in PM&R, there's a billion physical exam maneuvers that you'll do, and it'll help kind of lock in your your diagnosis. And so essentially, part of your job in residency is to learn all these physical exams. So when you see someone who comes in with back pain, knee pain, shoulder pain, neck pain, you're able to use these to help differentiate, hey, is this or this? Is this or this? So to summarize, all those special tests that came back positive are positive for something known as, are basically positive for some damage under the patella / involving the patella. And then the negative special tests have to do with ligamentous and meniscal like diagnoses, and they were all negative. So there's a bunch of them. I'm not going to belabor you guys with that. So I already kind of pointed you guys in the right direction in terms of differential diagnosis. Anytime you see someone, even though something's unlikely, you got to just keep it in your differential diagnosis, because patients will surprise you. It'll end up being like the thing that you least expected, but for the most part, it's exactly what you've been kind of trained to think about. So first on my differential diagnosis is something called patellofemoral pain syndrome. Sometimes it's called runner's knee, jumper's knee. That's what it's commonly known as. I didn't know about this in undergrad. I didn't know about it until I was in med school, so I don't expect many of you guys to know about this syndrome, but essentially what it means is that the patella that's supposed to sit in your groove, the patellar groove, and slide back and forth like this, is deviated to one side, typically the lateral side, so the outside of your leg. And so when that happens, the patella starts grinding on the bone. And when you start grinding on the bone, you start getting arthritis. And so that specific type of arthritis is called chondromalacia. And that just means that the cartilage underneath the patella is starting to get some arthritis, some damage to it. So obviously, generalized knee osteoarthritis needs to be in the differential whenever somebody has deep knee pain. Did they have any ligamentous injuries? Did she do I don't know, like, did she get tackled? Did she play football? Did she, what was the mechanism of injury? Did anything happen? Did she stop while she was running really fast? Did she pivot on a planted foot? Also meniscal injuries. So you have the medial and lateral menisci, and they serve as shock absorbers, which are commonly injured in all sorts of sports. You have the IT band, which is the iliotibial band, which all of you guys can feel on the side of your leg, starting at the top of your hip all the way down to your knee. That can be really tense, contracted, and that can cause knee pain as well. And then you can have patellar tendonitis. So the quadricep muscle, your quads on the front of your thigh, they go from your hip, and they actually have an attachment that goes over the patella and then onto your tibia, which is the bone right below your kneecap. And so did they just have tendonitis? So this patient had patellofemoral pain syndrome. Some of the things that kind of clued me into it while I was reading that history is the fact that they mentioned, they have difficulty with prolonged sitting, going up and down stairs, and then some of the physical exam maneuvers. So some of the things that can lead to patellofemoral pain syndrome are these kind of weaknesses in muscle groups. So as I've mentioned here, you can have weak quadriceps, weak medial quadriceps. So if the inside of your thigh is weak and that attaches to the retinaculum near the patella, if that's weak, the lateral side, the outside of the leg, is pulling harder on it. So obviously you're going to have a little bit of deviation to the lateral aspect. You could have weak hip extensors and abductors that can lead to it. You can have a tight iliotibial band, which is the band that goes on the lateral aspect of your thigh from the top of your hip to your knee. And what that does is that also attaches to the retinaculum that attaches to the patella. And so when that's tight, it's going to pull it laterally, right? So anytime you pull the patella out of its groove, it's going to cause that friction. It's going to cause damage to the underside of the knee. And so for treatment, this is what we do on a day-to-day basis. You always start off with conservative management, right? So rest, ice, NSAIDs, which is ibuprofen, Motrin. There's a bunch of other ones that you guys will learn about as you guys go on, Celebrex, Mobic, a bunch of them, right? That are very helpful. Something called Voltaren gel, which is basically like ibuprofen, but it's a gel form. So you can actually apply it almost like it's like Bengay or something like that. So there's a lot of different medications that you guys will learn about as you guys go on. It's not just Advil, it's not just Tylenol, it's not just ibuprofen. So There's a lot of medications you guys will learn about, and they get to be used in different scenarios. And physical therapy, we send to them to help improve some of these weak muscle groups. So on the previous slide, we kind of mentioned, some of these things that can lead to the patella deviating off laterally, that can lead to this symptom. So in short, the best thing that you can do is help them through physical therapy. The problem is sometimes they have so much pain that they can't tolerate therapy. So what do you do then? And you've already tried resting, you've already tried ice, you've already tried, medications that haven't helped. That's when we step in and we do injections. Cool part about injections is you can either do it via ultrasound guidance, or you can do it landmark guided. So you can, if you know the anatomy really well, you can do it just using your hand, feeling out the landmarks of the bony segments and knowing exactly where that joint capsule is. I did 2 this morning, didn't need an ultrasound. Sometimes if you have a heavier patient where there's a lot of body tissue overlying and you can't really determine where you're going, that's when ultrasound comes in super handy. There's a couple different injections that we can do for this type of symptom or syndrome. And first thing that you'll probably try is a steroid injection. Steroids have this huge bad connotation to them. The reality behind it is it's not harmful as long as you don't do too many of them, right? So in our practice, we can do up to 4 of them per year, so spaced out every 3 months, and you're completely fine. You're not going to cause too much harm to the rest of the body by doing this. Of course, you have to keep in mind any other medical complications that they have. Do they have diabetes? Do they have any other kind of medical complications before you start doing these things? But pretty low risk as long as you do it judiciously and you space it out. Steroids, the idea behind them is it reduces inflammation. So anytime you have arthritis, anytime you have damage to a cartilage, damage to a bone, it's going to flood the area with inflammatory markers. What a steroid does is it's a very powerful anti-inflammation agent. So it will help clear up that area. The next 2 that I mentioned, you guys, I'd be very surprised if you guys have heard of it. Awesome if you guys have, because this is some of the most latest stuff on the market and latest stuff that we're using. PRP is the short term. It's actually known as platelet-rich plasma. A lot of athletes get it because PRP and prolotherapy are what's known as regenerative medicine, and it's also termed as orthobiologics. So the idea behind these is they actually stimulate inflammation to the area, and they recruit growth factors to help re-heal the area and supply some pain relief. And it's shown some pretty good efficacy in certain joints. So the knee is one of them. And then for people who have tennis elbow and golfer's elbow, it's been working pretty well as well. So super new stuff. Another amazing thing about PM&R, it's got a bunch of new stuff coming in its future, and there's so much more to learn about it. And it's great. There's a lot of modalities that are going to be coming out by the time you guys are in residency, by the time you guys are practicing. So it's an ever evolving field, just like everything else, but there's some really cool stuff coming out in this department. So that's the end of the case. I know you guys supplied a good amount of questions.
Yeah, if you want to, so all the questions should be in the chat. So whenever you're ready, you can just go through them and answer them.
Yeah, so I'll go through them. So first question, what is the difference between physical therapy and physiatry? So physical therapy, as you guys know, is its own kind of schooling, everything like that. They focus strictly on just the regimens on how to improve function, how to improve stretching, how to improve, different modalities to help strengthen someone. Physiatrists themselves do not actually go into the rehab gyms and help stretch them out. We don't help them with, training. We don't help them with re-strengthening. We guide it. We tell the therapist exactly, hey, this is the diagnosis. I think they would benefit from these type of exercises. We tell them, I think they would benefit from, some of these modalities. But we ourselves do not do any sort of the physical therapy ourselves. We don't do any sort of re-strengthening. We don't do any stretching with them. As a physiatrist, you still play the doctor role. You still play the diagnosis role. You're the one diagnosing. You're the one providing the medication management. You're the one providing different modalities like injections. You're the one providing different modalities like acupuncture, dry needling, And in a lot of these more complex cases, like the neuro cases, like stroke and MS, multiple sclerosis, and spinal cord injuries, you know, it's a whole different level of scope of medicine that physical therapists are not trained in, right? So physical therapists are amazing. You know, for those of you guys who are interested in it, it's a great field. But just know they play a very, very different role in the healthcare system. Give me 1 second, guys. Next question, what rotations are common for someone going into PM&R? So I'm assuming that's a medical student asking that question. So for rotations that I did and I would highly recommend, let me start off backtrack in undergrad. I think everybody in undergrad should take anatomy at some point. It will help your life if you plan on going into medical school. You have to take anatomy in medical school. I would knock it out while you're in undergrad, just so you have a little baseline understanding before your first semester of med school hits and they're blasting you with anatomy. That's first recommendation. Second recommendation is for people who are in med school right now who enjoy the idea of PM&R. I would highly recommend doing a sports medicine rotation. I would highly recommend doing a PM&R rotation. I would highly recommend doing a neurology rotation and an orthopedics rotation. So the reason why I say those four in particular is because with sports medicine, you're going to see the entire musculoskeletal world, right? You're going to see all the injuries from neck to toes, you know, like all the injuries that occur on a sports field, but also all the injuries that occur with work-related injuries as well. So you're going to see a wide variety of things. A lot of PM&R docs end up doing their fellowships and specializing only into sports medicine. A lot of PM&R docs work as team doctors. You know, that's a great rotation to do. I did that when I was in med school. PM&R rotation is amazing because you truly get to see what it means to be encompassed in all of those fields. You get to deal with the neurology patients, you get to deal with the sports medicine related patients, you get to deal with traumatic brain injury patients, you get to deal with spinal cord injury patients. You get to see the full diverse aspect of what you're going to truly be doing as a physiatrist moving forward. And then neurology is great because even though we might not be dealing with the high intense level of neurology cases, we see post-stroke patients as a majority of our inpatient population, right? So it's nice to have that background knowledge of, you know, what kind of stroke did they have? What does that result in? What kind of weaknesses will they have because of this stroke? Laying a foundation is always good when you're going to be working with those different disciplinaries throughout your life. And then orthopedics is amazing because even though, for example, for me, I never wanted to sit in the OR for 4 hours, right? I like my procedures being short and simple. I like them being stress-free. I like them being non-emergent, which is everything that PM&R is. You know, none of our cases are emergent. None of our cases are going to take 4 hours. None of our cases are going to be, you know, super stressful. It's all, you know, it's all intended to help benefit the patient. We do a lot of cool procedures, including radiofrequency ablations, which just means burning the nerve. We do, you know, joint injections. We do ultrasound guided injections. We do fluoroscopy guided injections. Fluoroscopy, for the people who don't know, is live X-ray. So nowadays we have the blessing of the technology where we can actually see a needle go in as we are putting it through the skin into the spine on a nice little fancy screen, and that's known as fluoroscopy. It's wonderful, and it makes things a lot more pinpoint accurate. And the beauty behind doing an orthopedics rotation is you get to see what level people need to get to before they need surgery. You truly do. So having that understanding of, you know, like not having to send someone too early or not having to having that idea of, hey, this patient probably needs surgery versus, hey, this patient doesn't, is a huge difference maker. So that's very important. So you know, I would recommend those fields for sure as a medical student to do rotations in. How many patients do I see every day? You know, before COVID in my outpatient clinic, I would see about 8 to 10 patients every day. Now with COVID, you know, it went up and down. Sometimes it was more because we saw a little bit more telemedicine visits, and telemedicine visits are shorter because we can't do physical exams. but it's weird. We're all in a weird state of kind of, you know, like ebbs and flow with what's happening with COVID. So sometimes we'll have a packed schedule. Sometimes we'll have, depending on if there's more heavily restricted lockdowns, you know, not as many patients. Next question is, what interests you about this medical field? So for me, I'll tell you guys, you know, I had some personal experiences with a grandmother who experienced a stroke. I saw how amazing the physiatrist took care of her. I saw how much they were involved in her care and how much it truly just doesn't depend on just like the physical therapy side of things. There's a lot of medication management. There's a lot of, you know, a lot of procedures that take place, you know, in the background, that physiatrists are the quarterbacks of. You know, they're the leaders. They're the ones who are guiding this through. So I had some personal connection to why I chose this field, but outside of that, I like to do procedures. I'm a hands-on type of person, but I'm also very heavily involved in my patient's care. So I love talking with my patients. I love being able to sit down. I love being able to have the luxury of having a conversation. And you're able to do that as an outpatient PM&R physician. We're not the typical physicians who only have 15 minutes with the patient. We typically get a little bit more because you have to do a physical exam. So even though you're doing a physical exam and your patient appointments are like 30 to 45 minutes, you have enough time to get to know them. You have enough time to build a rapport. Like I mentioned earlier, I like to do procedures, but I don't like to be in the OR for like 4 hours. So all of our injections at maximum will take us 10 to 20 minutes. If you're using the ultrasound, maybe 30 minutes. So it's really, really nice. And the other thing is there's no emergencies in the outpatient side, right? So like if you're working as an outpatient physician, you will never be on call. You will never have to wake up in the middle of the night. There's never an emergency. If it's an emergency, they're either going to ortho or they're going to neurosurgery. They're not coming to you. So that idea of not having on call was a big thing for me. I'm very big into lifestyle, and I think all of you guys should take this as one of the bigger advices that I give to you. Please maintain a work-life balance. You know, it'll pay dividends to you as you guys move on throughout your career. You know, I truly value lifestyle a lot. I want to have a good family life when I'm older. I want to be able to be engaged with, you know, my family as I grow older. So, like I said, it's typically an 8 to 5 job. Some physiatrists only work 4 days a week. It pays very well. You know, the average salary last year, according to the Labor Bureau, was $306,000, right? So that's a pretty hefty salary for someone who's only working 5 days a week. So that's, you know, it compensates well, great lifestyle, a very, very rewarding field. Being in the military, I got to see so many people who have given up their freedom and their life and their you know, they put their lives up on their line for us, and to come back and treat them after they have blast injuries, where they have amputations, where they have, you know, traumatic brain injuries from having blasts that led them to have a concussion. Truly rewarding. And there's nothing better than being able to restore people's function. I will tell you that there's nothing more rewarding than that. So I had a patient who told me she was having shoulder pain, and I gave her a shoulder injection that, you know, helped her get back rehabbed, was able to tolerate physical therapy. And she came back at my follow-up visit and she said, you know, thank you. You know, like, you're the reason why I'm able to hold my baby up again. You know, like, that stuff really goes far in terms of how you feel when you're working. And it's very, very, very rewarding field. That's all I can say. It's an amazing field, amazing lifestyle. If you guys are interested in something where you still have the clinical background, you get to still talk with patients, but you get to still do procedures, I highly, highly advise you guys look into this field. What subspecialty are you considering pursuing if there is one? So I like pain medicine a lot. I think pain medicine is somewhere we do need more physicians who are coming with a new generation of thought. The old generation is, hey, they're in pain, let's just throw pills at them, let's, you know, quiet them down. So we are the new generation. We get to dictate how medicine is performed moving forward. You guys should all think about it like that. Even though you're not in that position right now, you shortly will be. So you will be the one to dictate how future medication works and future medicine works. So for me, that's a field where I feel like there's a lot of improvement that could occur, and there's a lot of new technology in that field. And I love working with new technology, new things. So It's an ever-evolving field, just like most of medicine, but there's a lot of things being done right now in the world of pain medicine that just super, super interesting for me. So, and more procedures, obviously. So it's pretty good. Why did you go into medicine? Did you have a specific moment in your life that was an epiphany for you? So I did not have a specific moment that was an epiphany for me. Since I was a little kid, I've always been fascinated with the idea behind doctors. And from being fascinated with doctors, I got interested in pursuing that as a career from a very young age. So my parents never pushed me into it. My parents never forced me into it. Actually, I'm the only doctor in my family, and everybody else's business. So, like for me, it was something that I've genuinely to be interested in. I've always been interested in science. The idea of science has always intrigued me, and ever since I was a little kid, I was intrigued with doctors, and it just kind of went hand in hand. And I always enjoyed talking to people. I know medicine gave that opportunity to me, so it all kind of just fell into place. So I didn't necessarily have an epiphany.
All right. So I don't mean to cut you off, Dr. Sid. We would like to thank you for joining us today.
Yeah, no problem.
In today's web seminar. I hope everyone had an opportunity to ask as many questions as possible and gain a little bit more knowledge on the PM&R and what Dr. Sid does. So thank you so much.
No problem. And guys, if you guys want to reach out to me, I'm sure these guys can, I think on the Instagram itself, I'm tagged on it. So you guys can feel free to just throw a direct message and I'll get back to it as soon as I can. I apologize if I can't get back immediately. As I'm sure you guys will see, eventually you guys will be quite busy as well. So, I'm more than happy to help out, happy to answer questions, happy to mentor. So feel free to reach out. I'm always available. Just might be a little bit slow to respond, but I'm here for you guys. I was not too long ago in your shoes, so I know all of the anxiety, all of the emotions that you guys are going through.
Sounds good. Thank you so much. So for the rest of you guys that are on this live, we've posted the link to the Google Forms, and it will be open till about 8:50 for you guys to fill out. So hope to see everyone's responses soon, and thank you for joining us today.